Welcome! In this lecture, I will describe some important microbial diseases of the respiratory system. As with the previous lectures, I will start with bacterial diseases. The respiratory system works closely with the musculoskeletal and cardiovascular systems to deliver oxygen to all the body's tissues and cells. The respiratory system consists of the nose, the mouth, the throat, the trachea, the bronchial tree, and lungs. Any and all of these structures can become infected with pathogenic microorganisms. The nose, mouth, and throat are normally colonized with a diverse ecosystem of microbiota. Some of these normal flora organisms compete with pathogens and protect the host from infection. The trachea and the bronchial tree, as well as the lungs, should be relatively sterile. Chief barriers to infections in these regions include flushing mechanisms of ciliated cells and mucus, as well as an army of patrolling macrophages. Let's take a look at one of the most common bacterial infections of the throat first on the next slide. Most microbiology students have experienced a bout with strep throat. Along with ear infections and urinary tract infections, strep throat is one of the three most common reasons antibiotics are prescribed in the U.S. Strep throat is caused by Streptococcus pyogenes, otherwise known as Group A strep or gas. Students should recall that all streptococcal species are gram-positive cocci in chains. In contrast to staphylococcal species, strep species are catalase negative and won't grow on salt agar. If a patient presents with a history of fever and an extremely sore and red throat, as seen here, the clinician will certainly want to rule out strep. A rapid screening test can be done on the patient by swabbing the inflamed area and running an EIA, or enzyme immunoassay. There are many different types of rapid strep tests on the market, but most are based on using specific antibodies to detect Group A strep antigens in the sample. The colored line next to the T for test indicates a positive. The C stands for control. If the rapid test is negative, but the clinician still strongly suspects strep, a follow-up culture is done on blood agar. There are hundreds of normal flora organisms in the throat, including many other species of Streptococcus. Streptococcus pyogenes, though, is the only one which is beta hemolytic and also sensitive to bacitracin. If you look at the plate below, you can see those characteristics being displayed. You can also see where the laboratory technician has stabbed the media with a loop twice in order to push the bacteria down into the anaerobic regions of the plate. The increased hemolysis in this region is also a characteristic of Group A strep. Since untreated strep throat can lead to much more serious complications like rheumatic fever and glomerulonephritis, it is appropriate to aggressively treat with antibiotics. Classic treatment for Group A strep is penicillin family drugs, like amoxicillin. The next bacterial infection I will describe is diphtheria. Prior to the antibiotic and vaccine age, it used to be a major childhood killer. Diphtheria is caused by the bacterium Corynebacterium diphtheriae, which is a gram-positive rod. These rods tend to stack on top of each other and display an irregular arrangement known as palisading. or even Chinese lettering. The genus is also notable for its intracellular inclusions known as metachromatic or different colored granules. These are stored inorganic phosphates that bind tightly to basic dyes. Some strains of Corynebacterium are harmless and can appear as normal flora in the nasopharynx. In virulent strains in children, the disease starts out with a sore throat, fever, an abnormally swollen or bull's neck. Without treatment, a gray membrane composed of fibrin, bacteria, and white blood cells forms on the tonsils, as seen here. This membrane is extremely tough and leathery. In fact, the name diphtheria comes from a Greek word meaning leather. This membrane continues to grow and may actually physically block respiration. Adults rarely get this respiratory form of diphtheria. Instead, adults tend to get a cutaneous skin form of the disease. Virulent strains of the organisms produce a potent exotoxin which decreases eukaryotic protein synthesis and can have a devastating effect on the heart, kidney, and nerves. The lethal dose for this diphtheria toxin is about 50 micrograms. Yikes! The toxin is so deadly that the first Nobel Prize in Medicine in 1901 was awarded to von Behring for developing an effective antitoxin for the disease. Check out this link to see how important this discovery was at the time. And some of you may know the story of the sled dog Balto, whose statue still appears in New York Central Park. When a devastating outbreak of diphtheria hit the isolated Alaskan town of Nome in 1925, Balto was the lead sled dog who delivered the antitoxin which saved the children there. Today, the yearly 1,000-mile Iditarod dog sled race traces the path of Balto's historic journey. Treatment options are available today. Erythromycin is the drug of choice for the organism. An antitoxin may be administered if the disease has progressed. The DTaP childhood vaccine uses an inactivated toxoid to stimulate active immunity. Adults should receive booster shots about every 10 years to maintain immunity to the disease. This figure illustrates just how important vaccines for childhood diseases really are. Prior to 1989, the Soviet Union did a good job at immunizing all of its children against diphtheria. When the Soviet Union broke up and the newly independent states took over, there was a complete breakdown in the infrastructure which administered vaccines. As a result, a massive outbreak of diphtheria occurred within a few years. Tens of thousands of children were hospitalized with the disease, and over 4,000 of them died. What was perhaps a good thing for democracy turned out to be a public health disaster at the time. This is a sobering reminder of just how vital childhood vaccines are. Otitis media, or middle ear infections, account for millions of doctor visits every year. Typically, these infections are a complication of common cold viruses. Normal flora bacteria, which inhabit the throat, build up behind the eardrum to cause pain and swelling, seen here. The three main bacterial genera responsible for otitis media are Streptococcus, Haemophilus, and Moraxella. The incidence of middle ear infections is higher in small children. because their eustachian tube is relatively small. The tube can become blocked due to swelling and increased mucus production that occurs when the child has a cold. As most parents know, the pressure on the eardrum can be extremely painful and may even cause the eardrum to tear or burst. The good news is that torn eardrums usually repair themselves, and hearing damage only occurs in repeated or severe cases. Standard treatment usually involves amoxicillin, the pink stuff seen below. If the infection persists and the organism is resistant to amoxicillin, augmentin, the white stuff, is usually prescribed. Interestingly, since the vaccines for Streptococcus pneumoniae have been available starting in the year 2000, the incidence of middle ear infections and the need for invasive ear tubes has dropped significantly. As Ben Franklin said once, an ounce of prevention is worth a pound of cure. Speaking of prevention, whooping cough is another important vaccine-preventable disease. The disease is caused by the bacterium Bordetella pertussis, which is a gram-negative rod. Lately, in the United States in general and in California in particular, we have seen an alarming increase in the number of cases of this potentially deadly disease as the result of the anti-vaccine movement. This figure from the CDC shows the national trends in whooping cough cases from the 1920s till 2013. Before routine vaccinations began, hundreds of thousands of children developed whooping cough in the U.S. every year. Effective vaccines dropped those numbers dramatically. Unfortunately, the recent trend is going in the wrong direction. Thanks, Jenny McCarthy. The disease itself has three main stages in its natural history. First, the catarrhal stage is similar to a cold, only with much heavier mucus and prolonged cough. Next, the disease progresses to the paroxysmal stage, where violent coughing and gasping for breath occurs. The disease is named for the distinct whooping sound patients make in a desperate attempt to get oxygen between coughing fits. It sounds a bit like this. Cough, cough, cough. Cough, cough, cough. The cough is so violent, it sometimes breaks the blood vessels in the eye and can even crack ribs. This stage lasts for weeks and gives pertussis the nickname the 100-day cough. Finally, the convalescence or recovery stage can take months before the weakened child returns to normal. Besides its capsule and endotoxin, or LPS, the organism produces two well-characterized exotoxin virulence factors. The first is known as the tracheal toxin. This toxin destroys ciliated cells in the upper respiratory tract and makes it easier for the organism to establish an infection. The second is known as the pertussis toxin. This toxin is secreted into the bloodstream and causes an increase in mucus production, a decrease in phagocytic cell function, and an overall decrease in available blood glucose for the body's cells. For a personal account from a mom whose child developed whooping cough, watch this video. You'll see that whooping cough is a terrifying disease that we should all be protected from. The organism is usually sensitive to erythromycin if it's given early enough in the infection before the toxins are produced. Of course, it's best to prevent the disease from occurring at all by giving the DTaP, diphtheria, tetanus, acellular pertussis vaccine to babies. All adults, especially caregivers of little children, should receive the Tdap booster. Do your part to prevent this disease in your children and in your patients. Make sure your vaccines are up to date. This concludes Diseases of the Respiratory System, Part 1.